Okay, I think we're about ready. So, hello everyone. My name is Lisa Drake, and it says on the home screen there that my colleague Matt Sweeney is joining, and I think I've also got my colleague Claire Temple here from Redmore Health, and we're delighted to be introducing this session with you today. This is part of a series of masterclass discussions to kind of help you all in practice, support your patients with long-term condition management. I'm going to switch my camera off in a moment just because I don't have the best broadband here, but I wanted to say hi to everybody just on screen. So I'm hoping you can all see the home slide. And you can all, lovely, thanks Ian. We've also got guest speakers here today. So we have Ian Wharton from Aid Health. Ian's going to talk to you a little bit about a project that they have ongoing in Suffolk. And we also have Grace Gimson from Holly Health and Dr. Alexia Pello, who's going to join us from East Ayrshire Health and Care Partnership to talk about their products as well. And as I said, this is part of a series of events that we're running. So quick housekeeping and agenda. I'm going to post the link to our long-term condition management webinar series in the chat in a moment. If you're just joining us and you didn't join through the booking link, please can you pop your name and your role in the chat, and also which area of the country that you're working in, and emails if we don't already have that. Got your mics and cameras off at the moment just while we're presenting, but when we get to the bit which is the discussion, please come on camera. If you're feeling a little bit shy, knock your camera off, pop your hand up, we can still hear you there. And if you really want to drop thoughts and ideas into the chats, please do that as we're going along, because we'll come back to the chat questions and make sure that we cover them. So I think what I wanted to say is, in various conversations, we're all passionate about using digital solutions to support patients and providers, but we still generally feel that the long-term condition agenda has been a little bit overshadowed, particularly in recent years, with the focus on access as a priority. So we're going to explore some strategies and tools, but we're also going to be asking you some questions, and we're not going to use any polls or that sort of interaction software, but I do want you to post into the chat if you can. I've got the chat open on my phone, so if you've got any questions at all, please fire them in there. We'll hopefully cover them as we're going along, but if we don't, we'll come back to them there. So just as a reminder for yourselves, if you don't know who we are at Redmore Health, we kind of sit in this sweet spot in the middle of policy and providers as yourselves in practices and PCN, policies and commissioners in terms of the NHS, standards organisations, but we also work with all tech and product suppliers, and our role as a tech agnostic company is to support them to increase their optimisation, use of their products, spread and adoption across all of their areas. So sometimes we get commissioned by ICBs who've bought a product, but it's not quite been utilised as expected, and that's where Redmore Health help. And one of these sessions today is really about raising awareness of good companies, products and services that are out there that can help you to think just a little bit differently. So if you were on the last session, you'll recognise this image. I shared it before. Like many of others who are there working with AI at the moment, I used AI to do the heavy lifting. I dropped lots of words into there, and it's given me this rather complicated diagram around long-term condition management. I don't think this is exhaustive by any way, but it is complex, and we're hoping to take a chunk at a time and share what's out there to help you. So we've gone past the point now where we know that long-term condition management is just nurses delivering QOF in practice. It cuts across the whole population health, how we might plan methods of care delivery and how we communicate this out to patients. And today's focus is going to be around self-care, self-management, thinking around lifestyle medicines and what patients do when they're not actually with us in practice, because they're living with these conditions 24/7, 365. And what we're trying to do, again, is hang on the back of the government's agenda, which is shifting from treatment to prevention, because if we don't do that, we're not going to remove that, or at least reduce that burden of poor health on the NHS. So before we jump into the case studies, I've got some fundamentals for you just to think about. I want you to pop into the chat if you can. But I'm going to start with medication because it's clearly an important element of long-term condition management. And I'm sure most of you have got patients who order meds and are otherwise well, and they don't want to come into the surgery. And conversely, you've got clinicians who've got a legal responsibility for prescribing safely, and they don't want to issue any meds without a review. So somewhere in the middle of that, we've got that dance to do to get people in contact with us, keep us up to date with how they're doing, we need to be able to prescribe for them safely. So how are you making sure that all of your long-term condition patients know how to order meds? Have you got repeat prescribing guidance? Are you working with your local pharmacist to make sure they don't overorder? How are the patients understanding what their role is in this? And as practices, are you optimising your use of the NHS app, things like EPS, ERD? We spoke to a patient group just recently and they said electronic repeat dispensing is the single biggest benefit to them. It means they no longer need to order through the surgery. They just go to the pharmacy and get the medicines. And yet, on average, I think we see around 10% of patients with long-term conditions set up for electronic repeat dispensing. Have a think about that one. I guess the next bit is your planned cycle. So how are you introducing what might be a cycle of reviews? Some of you I know have been using year of care planning approach. And if you were on the last session, Steve Leitner talked about developing teams within teams and really supporting those patients who benefit from continuity. How are you educating your patients to know about those different modes of contact? So are they waiting for those questionnaires or those florries to land? And do they understand that that is part of your care to support them? How have you guided them to understand that? And if you do have care plans in place, how are you sharing those with other practitioners involved in their care? You know, are patients understanding those symptom checkers and knowing how that relates to their specific condition and when to go beyond just minor illness and when they need to seek help? See, we talk about seasonal vaccination. Just wanted to check in with you. Those of you who are working in a PCN, if you've started delivering all those seasonal vaccinations as a PCN, have you lost sight of that multimorbidity that some of those patients have? And are you prioritising them, or are you basically just putting clinics on and it's first come, first served? So we hear a lot, those of us in the digital space, about patients self-monitoring, but how easy is it for those patients to upload that information into your clinical system? You know, have you got a really tight safety net so that when data arrives in, you know who to prioritise from a risk point of view? Online access, we are all big fans of online records access at Redmore Health. If patients who've got long-term conditions can access their information, they're often in contact with multiple healthcare providers, enabling their full records access so that they've got the correspondence, test results, etc., is much easier for them to share. This helps them to take ownership of their health because they're better informed and they can take more proactive steps. It also means that they might need to divert on your triage system. So I want you to think really carefully there around total triage, because some of these patients not just need continuity, but need to be able to escalate when they become unwell. So thinking about patients as experts and peers and lifestyle advice, are you thinking around how you deliver that? I've sat in clinics with nurses and heard them say the same information time after time in those 20-minute appointments. There's a real opportunity there around group consulting, maybe even led by expert patients who offer peer support. And if this is one of your interests, we've got a session coming up in February on that one. But that lifestyle advice, I think we're going to focus in on a lot more detail here. And then finally, that self-care advice, how are you sharing that information? So you may be aware that we offer social media managed service at Redmore Health. This isn't just a well-stocked medicine cabinet, this is when to seek help. And you can use that broadcasting information out into communities, even for people who don't have long-term conditions. Here's just an example of some of the resources that we've popped out over the last 12 months. And you can sort of drip feed this into your communities. So you're broadcasting this content, reaching millions of patients. Remember, families care for each other, so they can still absorb this information, even if they're not the ones with long-term conditions. So that's kind of enough about me. Claire's just going to pop up for 2 minutes, because if you've joined through our digital and transformation network, Claire's just going to spend a moment talking to you about that.
Hi, thank you very much, Lisa. So yeah, if you're not already a member of our Digital and Transformation Network, you can sign up. It is free for everybody. There's a wealth of resources, information, as well as some great conversations about all things digital and transformation and things like this long-term condition support. It includes a community forum, free webinars, a regular newsletter with information that's relevant at the moment, some exclusive white papers, Lots of resources and templates free for everyone to use, and free events like this one today. You can scan the QR code there to sign up. There's also going to be a chance, I know that Grace is already a member, and we'll get Ian signed up as well. And you'll be able to speak to them about this, because all this information will be held on there as well. If you've got any direct questions that you want to ask them, it'd be a great place for you to communicate about that and have a conversation. Thanks very much, Lisa.
Yeah, thanks, Claire. And I think that sharing space, a number of us are in, lots of different WhatsApp groups. I think the idea is you don't lose the thread. You can ask questions in here of your peers. We've over 500 members on this. This is where we need to really engage with you and share information. So I'm going to hand over now to Ian. Ian's been patiently waiting there. Ian's the CEO and founder of Aid Health. He's going to share the work that they've been doing in Suffolk. Ian, happy for you to take over screen sharing if you want to share your slides at this point.
Great. Yes, thank you. I'll do that now. Bear with me 1 second. So all being well, you can see the cover slide. Maybe Lisa, if you could let me know when that's complete.
Yeah, it's there. Yeah.
Perfect. Okay. Well, thanks, Lisa. Hi, everyone. Delighted to be here and join you also alongside Holly Health. So, very quick overview. We started Aid Health 4 years ago. We've had our product in the hands of patients for at least 3 years of that. And what we do is really straightforward in terms of goal, at the very least, which is to help patients self-manage chronic conditions, but specifically with an angle on comorbidity. And the way we do that is through using conversational AI. And this is a strategy we've had at least 4 years, maybe you can go back 5 now, as conversational AI as one way. Certainly, we think one of the most meaningful ways to start addressing some of the challenges of chronic conditions and also the burden that they place on the healthcare system. So what I'm going to do, I'm going to talk very briefly about what Aid Health is, very kind of succinctly how it works, and then I'll go through the case study, in this case with Suffolk Primary Care and some of the outcomes, some of the learnings we had about deploying our technology in their population. So just very quickly, there's two, I mean, the people on this call very well know these stats, so we don't need to dwell on them, but there are certain challenges of long-term conditions that I think remain unaddressed. They're very, very complex things to try and solve. And one of them is, how do we best support people with comorbidity? And I guess what the interesting thing from our perspective here is just the speed at which this has escalated. So in less than 10 years, we've gone from having 1 in 10 people to 1 in 3 people being admitted to hospital who present with 5 or more chronic conditions. And obviously, we all know the kind of the broad impact of that on the healthcare economy, which is mortality goes up, both inpatient and outpatient care goes up. We know that functional status goes down with 2 or more comorbidities. That's when care can get very expensive, both at the kind of primary and secondary care level. And we know that practice visit goes up with people with comorbidity, on average about 12 visits per year with someone with 2 or more conditions. So this is very difficult. And honestly, the patients we've spoken to over the past 4 or 5 years, they echo everything that the NHS desires, which is holistic care rather than disease-specific care. And one of the stands that we take, one of the reasons we started the business was that I don't think either party has the tools to do that management effectively. So as challenging as it is to support multiple conditions in one platform, that's our whole reason for existing, which I'll talk about in just a moment. And then the second unaddressed challenge, which I guess is kind of connected. Now, some of you may remember when the NHS House of Care framework was established, and to some degree it's still operating today, just maybe under different terminology, there was this desire for everyone with a long-term condition to have a written care plan. And we think that's absolutely the right strategy still now. And to NHS's own data, kind of the more recent study they did, which is just over kind of 5% of people actually have a written care plan for their long-term condition. So the question is, well, why does that matter? And it matters because, as we all know, retention of information for patients is really hard. And there's kind of countless studies, probably most famously by the Helmholtz Institute, which shows just how challenging it is to remember any information we're given that's of a clinical nature. So lots of studies show up to 80% of people forget everything they've been told the second they walk out the clinician's door. So perhaps we don't talk about this enough, like information as a determinant of health. It's something we certainly believe in. And it's not just the delivery of it, it's the kind of the continued support and how do we help fill that gap. And these two things in combination is certainly what we're trying to solve. So Aid, and it's kind of very simple kind of illustration is we're a digital long-term condition platform with kind of two goals, but we kind of come patient first. So we're really trying to help patients self-manage, and we're trying to give clinicians insights and data that is otherwise very hard to come by, that might help them enhance the care they provide. So AID is a platform in two halves. It's a native mobile app for the patient, and that has kind of three purposes: kind of medicines optimization and improving adherence on one hand, giving them tools to monitor their health in all different ways, whether it's biomedical things like blood pressure or peak flow, and symptom severity right down to patient confidence or mental well-being, and also then the provision of structured education to help improve their level of health literacy. On the other side is the clinician platform. This is a browser-based platform that presents all of that data, both at a population and the patient level, to help clinicians determine what the right course of action is, or what the right conversation, the right method of engagement is with their patient. And it's designed really for one moment, which is the moment of consultation or annual review. So firm believers in shared decision making, and both patient and clinician are given the exact same data to have more meaningful and arguably more efficient conversations off the back of it. So just very quickly, there's kind of two things that we focused on. One is kind of multi-morbidity. We launched specifically and kind of purpose built for kind of multi-morbidity. So we launched 4 years ago or so with support for asthma and type 2 diabetes. We later added hypertension. We've just finished COPD, and shortly over the next quarter we'll release chronic kidney disease. Our goal basically is the top 10 long-term conditions in one platform. Patients tell us time and time again, on no uncertain terms, I cannot have 3 or 4 or 5 different apps to manage my health, and also clinicians can't either. So anytime we deploy in an organization in the NHS, one kind of 12-month license to AID gets access to all conditions. We don't penalize populations for being poorly. We don't charge per condition. And in fact, any new condition we add gets kind of rolled into that 12-month contract during that period. And the second thing is just how we interact with patients. So I know AI is firmly in kind of cultural discourse today because of the government's recent investment and various other things, but we've been on this path for 4 years, and it's our view it's the only logical way to support patients individually, but also at scale. So AID has short conversations, often that are daily, with patients to help them manage their health in all different ways. And a couple of things here. So we don't diagnose and we don't suggest changes to prescriptions. So we're firmly kind of patient support, educational material, helping them with their day-to-day. But here's the difference, which is, on average, 0.01% of a patient's time is with the healthcare system because of the pressures that you're all under, and not light there isn't the end of the tunnel for that to change anytime soon. But with progressive technology, that can change to 100% of the time. And the stance we take is very much in the augmentation of clinical care, not the replacement of it. And I think that's the only real role that AI has in healthcare. Maybe ever. We may never hold the wisdom to wield the power of something else, but certainly for the next kind of 5 to 10 years, our stance won't change. So just some of our work with Suffolk. A little over a year ago, we started working with Dr. Neil Macy, who was the then clinical director of Suffolk Primary Care. He's still the lead GP of Stowe Health. They've since kind of separated from one another. We're still working with Neil in various ways. Now, this project was to offer AID initially to a really small subset of their asthma population, which by Neil's words was the most challenging subset of the asthma population, which is people who were classed as overusing their reliever inhaler. So patients with 4 or more SABA prescriptions per year. And the task here was, can we educate them on kind of preventative medicine, how to take their inhalers better? How can we increase their adherence to that preventative medicine? Can we log incidental medicine use and learn things off the back of that? And having rolled out to that very small population and seen the results, AID was then very quickly rolled out to the entire asthma population, age 18 plus, over 7 GP practices in Suffolk Primary Care. So I'll just touch on some of the things that we've learned, some of the things that we think is interesting from a future facing, how we support patients with long-term conditions, but also technology that's available today. The first question is, and always should be, does anyone want this and do they use it? So there's no other way of looking at this. Retention rates of health and wellness apps for patients is comically bad on average. So any health and wellness app given to a patient, a standard industry standard retention rate after 30 days is 3.5% of people are still using that service. which you could argue that maybe one person getting benefit is enough economically, but very difficult for kind of population management. So that's the first thing. What we saw with aid in this population was about 22 times the sector average. So after 30 days, just under 72% of people are still using aid every day. We've got a really high metric for what we class as retention. You have to open the app and take one other action. It's not just keeping the app installed on their phone. And actually, even after kind of 6-7 months, what we're still seeing is just over 40% of people still using the service. The next question is, well, who are those people? We have no upper age cap on aid health. I don't think any digital intervention should have an upper age limit. I think those days are long gone. You can make that argument. So in this instance, our oldest user was 76, median age about 50, and we capture area classification during patient onboarding, and that included things like challenge diversity, hard-pressed aging workers, outer city hardship, and all of these people were using aid perfectly proficiently and with kind of really good kind of qualitative measures as well. The second thing is, well, for those people who use it, how are they using it? Now, it's probably fair to say any typical long-term condition patient probably has between 2 and 4 conversations with the healthcare system per year. If you're a kind of frequent flyer or particularly challenged with your condition management, maybe it goes to 7 or 8. On average, aid had 4 conversations per patient per day. And actually our kind of 90th percentile, it was between 7 and 8 conversations per day. So we know over the course of that time, people actually want to interact with these systems, much more so than we had anticipated prior to launching this project. So these conversations include standard medicine reminders and acknowledging adherence or otherwise to that medicine, saying why they've skipped medicine and the reasons for it, covering things like symptoms, mental well-being, patient confidence, conversations about vaccination programs and the importance of them, plus really kind of specific, condition-specific conversations that occur maybe only even once a year. But again, really promising signal that actually patients are perfectly willing to integrate these systems into their lives. Again, fully under the knowledge that this is not replacing their clinicians. It's things to help them and augment the care they are already receiving. Next is more kind of 2 clinical metrics that we care about most, which is adherence to medicine and then patient confidence. So non-adherence, widely recognized as leading to higher all-cause hospitalization and all-cause mortality. There's no amazing measure of adherence rate. I think everyone on this call will appreciate that. It's very, very hard to know exactly what a patient is doing without an intervention. The medication possession rate is about as good as we're going to get. And for inhaled corticosteroids, which is what we focused on in this study, it ranges kind of as high as 50-ish%, as low as 15%. There's plenty of evidence to show that if you can increase that even by kind of 20-25%, you can have a reduction of 10% in exacerbations that might lead to hospitalization. So really promising on the adherence piece, and then also promising on patient confidence. There's enough studies to show that if you can increase a patient's knowledge of their condition, sense of ownership, sense of autonomy, that you get kind of downstream healthcare reduction. So we have our own measures for patient confidence, things like, do I have the skills to manage my condition? Do I understand my medicines? Do I feel involved? And we saw upticks in all of those things kind of pre and post this rollout of our technology. Now, I'll pause for a second on our own stats. I think this is an important thing to discuss, which is what really is the role of these types of technologies in a clinical setting. And again, just I'll state this, which is it's not replacement of clinicians. I don't think anyone who takes that route will do it effectively, because we're not there yet as a society. We don't have that understanding of the technology. And there's lots of research, lots of studies show, well, where is it most valuable? And this is a really interesting study. It was done by the University of Southern California, and what they basically compared was patient willingness to confide in either a digital agent, in this case conversational AI, or the human clinician. And what the researchers found, that it wasn't even close, that people who didn't think there was a human at the end of the conversation were much more honest about their symptoms. They were more open. They were even more likely to show intense signs of sadness, which you could argue is a really hard thing to signal in front of a person. And the benefit here is that as a supplement to clinical care, these systems can surface things that might otherwise not be surfaced. There's loads of studies that show patients withhold medically relevant information from their clinician because they don't want to let them down or for fear of judgment. Now, they're two big barriers to get over, but again, technology can get around a couple of those things. I think we see some of these signals at Aid Health. So during the course of this rollout of Aid Health in Suffolk, we had patients tell us things that we think otherwise they might not have told someone. So for example, 50% of patients willingly told Aid they didn't have an asthma action plan. There's a direct kind of correlation in higher mortality if you don't have one. But also over 25% of people told Aid they stopped taking their medicine when they feel their condition is under control. Again, not so great from a kind of chronic medication perspective. But if clinicians know these things, then they can take much better action off the back of it. We don't necessarily do anything in these moments, but it's arming clinicians with information that might help them have good conversations. And then from a economics perspective, we looked at one piece of asynchronous education that Aid delivered, in this case inhaler technique, and kind of doing loose exploration here with Dr. Neil Macy. Broadly speaking, per 1,000 asthma patients, we can save about 300 clinical hours, if indeed that practice did want to educate on inhaler technique, which you could argue is necessary because as few as a quarter of people have good inhaler technique. So the savings on asynchronous education or asynchronous discovery of certain things is quite extraordinary, really. And the final thing I'll say just before we wrap up is, well, how did this get rolled out? I'm having been in design and innovation for 20 years, I know that the fear of deploying these technologies, which sounds burdensome, sounds expensive, sounds like going to derail my clinical staff for 2-3 days, which it just isn't the case for not only us, but I think a lot of technologies. So how it worked for us, we rolled out with one small cohort deliberately, the hardest to reach cohort, to see how do we do that. Those patients were invited by one SMS, in this case System 1, but you could use Hero Health, you could use AccuRx. Then we kind of evaluated that briefly. Did it still fit within the clinical process? And then there was a wider rollout. I think it's a pretty good strategy for any technology deployment. Start small and roll out after some initial evidence and once you've got any kinks out. And just in terms of time required, well, in this case, there was 0 GP hours involved in the rollout. Nurse hours, probably kind of 1 to 2 hours total. That involved some kind of group webinars, some asynchronous material we sent. But from an administration perspective, it was under 4 hours to identify the cohort, plan some prep with us, get some details, roll out the SMS, and then we kind of take over from there. So again, it needn't be terrifying. These technologies, not just us, any like us, there are ways of getting them into the hands of your patients without overt burden, certainly to distract you from the challenges you already have day to day. So I'll pause there, but yeah, thanks very much.
Thanks, Ian. I really appreciate that. I've made myself some notes because rather than ask you questions now, I'm going to hand straight over to Grace and to Alexia for them to do their session. And then what we're going to do is come back to everybody to raise some of those questions. But thanks, Ian, really insightful. Hi, Grace. You ready to share?
Oh, yes, perfect. Thanks, Ian. That was super interesting. And it echoes a lot of the learnings that we found at Holly Health as well. So the fact that people are crying out for holistic support, looking for one place to manage multiple health areas, and also they are open to sharing more about what's going on with their health to an app, which it was surprising for us as well, but it definitely is the case for a lot of people. So I'm gonna grab my slides. And I think the fact that both of our companies have been on this call is really nice because we're both trying to address the same challenge of multi-morbidity and people living with mental health challenges, physical health challenges, just multiple challenges mounting up. However, we're slightly earlier in the cycle of kind of looking after people. So we're looking at supporting people from the more preventive side with their lifestyle behaviours at Holly Health. By the way, I'm Grace. Hi, everybody. Thank you for having me here. So I founded Holly Health almost 5 years ago. And it kind of came about from a long-term mission. I wanted to create something that combines psychology and technology ever since I was a teenager, and now kind of few decades later, I've been lucky enough to bring together a very psychology heavy and technology heavy team, which basically combines modern day psychological approaches to help people with changing behaviours. So today I'm going to introduce the problem area, talk a little bit about what we're trying to achieve with self-management and lifestyle behaviour change. And then I'm very lucky to also be joined here by Alexia Pello, who heads up the clinical director role in East Ayrshire in Scotland. So Alexia is actually going to take most of this presentation and talk about the practicalities of deploying a self-management digital tool to patients. I'm just going to kind of frame the problem that we're addressing first. So in case anyone hasn't heard about Holly Health, we are a behaviour change tool. It's fully digital. It's not actually AI, so it's all pre-coded. And that means it's very much in our control exactly what types of habits it's recommending to people. However, AI is getting more and more exciting, and we are looking to incorporate certain AI approaches as well. And going right back to the problem that inspired us to create Holly Health, so there are some really obvious things that I'm sure everyone's aware of, but of course, lifestyle-related chronic conditions are spiraling, as is multi-morbidity. And so millions of people need support for both mental and physical health. And an area that can be really helpful and has loads and loads of evidence around it is building habits. But people do need help to build habits. It's really, really hard to build sustainable changes on your own. So habit coaching is potentially a really impactful area there. There are obviously a large range of lifestyle risk factors, and everyone has a different combination of these. So any solution in this space has to be very user-centered and personalized to each person and their unique challenges. And then it can't be fixed as well. It needs to kind of learn how that person evolves. Maybe their mental health or their sleep improves, so the service needs to adapt. Of course, we have some challenges with resourcing. So NHS staff are at max capacity. We thought it was really important to build something that didn't need really any clinical time at all and didn't need change management either. And it's just about having a service that can run alongside existing healthcare services. We live in a very noisy world and have short attention spans because of all the things that are happening around us. So any support has to kind of cut through the noise, not just at the beginning of using a service, but also as people continue to use that service. And so it has to kind of nudge and cut through in the right ways. And importantly, we all know that there's limited budgets for prevention, and we have a very, very large scale problem. So we wanted to build something that's low cost, but highly scalable to populations. And those problems will apply to lots of different services. I will talk very briefly in a moment about Holly Health and how we address that. But just before that, I want to talk a little bit more about the potential and some of the things that I'm seeing in shifts in the NHS, NHS England and government and the Department of Health and Social Care, and some suggestions of where we need to go. So population health initiatives driven using technology have really, really big potential. But the NHS has really barely scratched the surface of what's possible using technology. Of course, we all know about historic public health initiatives, stop smoking initiatives and things, which are very low tech but high scale and very impactful. But now we're at the stage where technology can kind of drive us to the next level of impact by taking lots of individuals across a population, tailoring the risk factors that they each have and tailoring the coaching for each person so that we can kind of go beyond mass messaging to personalized messaging that's still low cost to deliver. So in the NHS and Department of Health and Social Care, the things that we should be thinking about are putting in place solutions which come in after risk stratification. So there are some really exciting things happening in risk stratification. So looking at who's most likely to attend hospital in the next 6 months. We've obviously got more and more health check services coming in, but there's very little planning at the moment for what happens after that. When you risk stratify thousands of people into a group, what do you do next? And we need to find large-scale ways to support them. We also need to deploy effective self-management tools at scale. Technology, again, is going to be really helpful for this. They must be effective though, so we must be looking at services that have evidence, have research, have loads and loads of user kind of data and feedback to show that they are impactful. We also need to educate more clinicians, ideally earlier in the cycle, so at university, on lifestyle medicine approaches, not just what lifestyle medicine is, but also how to coach people and to kind of find new ways for them to carve out time in their extremely busy weeks. So group consultations is a really good way of doing that, for example. And then ring-fence funding, we need much more of this for self-management and prevention. But optimistically, these shifts are starting to happen. We are seeing a lot more appetite with government changes. And so let's watch this space. I am confident that this year, a lot of this will be changing. And just very briefly, before I hand to Alexia to talk about her local deployment, a little bit about Holly Health. So we built this service to be a personalised and holistic coaching service. It gets to know each individual through an online chat flow with the Holly Bird. Holly is the coach, essentially, and it gets to know each individual, their current habits and behaviours, their chronic conditions and their health goals, and then kind of puts together a plan which it communicates with the user, but ultimately the user decides which habits they want to focus on. And then the service nudges and coaches the individual to achieve the appropriate changes for them. It's all about small, really achievable habits, and it's all about building up motivation, making people feel really good about the small things they're doing. So there's lots of gamification, lots of kind of behavioural economics approaches. And we're covering the major lifestyle risk factors across exercise, sleep, nutrition, mental well-being, social isolation, and things like drinking and smoking as well. And really importantly, it's not just about delivering the service to the end users, it's also showing what's possible to the commissioners and NHS organisations. So providing data aggregations which look at population health insights, typically in a lot more detail around lifestyle than you see in medical records. So you can see exercise levels, fruit and veg levels, things like that in the population. Sleep is a very insightful one. So many people not sleeping 6 hours a night, which is quite worrying. And then we provide these data insights to also look at what's the impact and what's the ROI, which is super important when funding is tight and you're looking at saving in one place in order to fund in another place. And finally, we're all about kind of building reputation and providing outcomes and data which you can trust and which you can see will kind of scale out over a population. The data shows that you can reach 10% of an adult population in primary care because the appetite is there to receive coaching, and the challenge is there in terms of how many people are struggling with either mental or physical health or both. We've supported about 50,000 people so far, but we have a long way to go, and looking forward to scaling up with ICBs this year. And I'm going to pass to Alexia now to talk about deploying Holly Health personalised coaching in the Ayrshire and Arran region. So Alexia, if I control the slides and if you turn your camera and mic on, hopefully that will work.
That's great. Thank you, Grace, and thanks for having me here. I'm Alexia Pello. I'm the Clinical Director in Ayrshire and Arran for digital services and also for East Ayrshire's Health and Social Care Partnership. Obviously, I thought it'd be useful to have a quick overview first of Scotland. So NHS Ayrshire and Arran is one of 14 health boards. We've got a population of more than 300,000 people. We're split into 3 health and social care partnerships, East, North and South. And we, in the East Ayrshire Partnership, host the primary care contract for the whole of Ayrshire. Now, over the coming slides, I'm going to cover the local challenge, what interested us in Holly Health, what we did, how we considered digital inclusion, and what our outcomes are so far. Moving on to the next slide. So I thought I'd talk about our local challenge first. Now, I think our local challenge won't be dissimilar from other areas in NHS Scotland and in NHS England. We've got rising rates of long-term conditions which can be caused by lifestyle risk factors. We also had a prescribing reform extreme team commissioned by the Health Board, which I chaired, which really needed to take a preventative approach to be able to be successful in reducing the demand on prescribing and also improving cost efficiencies. We've got a real capacity demand mismatch across our healthcare services, and although we've been looking at other routes of expanding our capacity, we really needed to be, again, preventative to reduce that demand. We've all got limitations and access to funding, and it's quite a fiscal climate that we're sitting in at the moment. And when we looked at what we would be able to deliver, it needed to be something that could be scalable and be able to be thinking more upstream to help people stay well and prevent their decline. And we well recognise in a rural demographic that we have in Ayrshire as well, that this lifestyle change support needs to be able to meet people where they're at, and we need to be able to make it as accessible as possible. We went to a local GP practice in East Ayrshire, first of all, to do some modelling on the data to look at what our service could look like and what the potentials were that we could take on. So looking at a list size of a practice with nearly 14,000 patients, we knew that 30% of the over 25s in this practice had obesity. We also knew that they had increasing rates in the diagnosis of conditions that can be affected by lifestyle, such as type 2 diabetes and non-alcoholic fatty liver disease. When we looked at the type 2 diabetes prescribing and took a presumption of those being prescribed 3 of the diabetes medications or maximum therapy, it was going to be at a cost for one practice of £113,000 per month. And knowing with those increasing rates, which in fact went from 42 to 70 per year within 2 years for diabetes, we knew that we had to do something preventative, and we could use this as an example to be able to access an innovation fund. We also looked at the non-alcoholic fatty liver disease rates, specifically because at the time, the waiting list to see a specialist for a diagnostic fibroscan was 2 years. We saw those rates had gone from 25 per year in diagnosis up to 68 per year in 2 years. And obviously, again, there was a potential there to be able to remove those risk factors and reduce the diagnoses if we look at prevention. We were successful in getting the Innovation Fund to be able to launch Holly Health. So we launched it, first of all, across 16 practices, which were all practices in East Ayrshire. And then we knew we were going to be able to scale to the other 2 partnerships, which would total 53 practices. We asked those practices to think about offering this service for free to their patients by SMS or by QR code, and they also all uploaded it onto their GP practice websites to offer a web sign-up route option. We made this available to any adult patient, and they would be able to complete a behaviour health check first of all on the web, and then set up their personalised habits, which we really liked the approach that this could still be person-centred even if offered at scale. We know the app offers daily nudging and compassionate coaching for them, and we were able to track the health outcomes at 0 and 8 weeks and at 6 months. And we were particularly interested in certain health models, certain health measures such as blood pressure, energy, weight management, and also looking at those 4 areas that Grace has mentioned, so sleep, exercise, lifestyle, and nutrition. For digital inclusion, which is really important because we are a rural demographic area, and also because we knew from a previous Tech Pathfinders project that we had an 18% of our population within one area without connectivity. So we needed to make sure we'd considered this. We made sure there were multiple entry routes. So there was the option of the SMS invite, there were also physical flyers and adverts on the GP surgery waiting room screens. We made sure that there was an easy sign up and onboarding process. So there was an option for this to be taking place on the web. They could also use a mobile tablet or a desktop computer, or maybe one even in a library. We knew that Holly Health had co-designed the process with older adults and people who are new to using phones and smart devices. And we also made sure there was support for people who do not have a smartphone, and they could still be able to print off the habit tracker sheet instead and receive their recommendations. We have a local alcohol and drug partnership group, lived experience team. So we worked with them and with Holly Health to make sure that we could get some input from their lived experience users, and they were, on the whole, well received for the Holly Health app. We also recognised when we saw the baseline data that these insights are really useful across our other programmes of work, and there were things that were coming out of our baseline information that actually helped in other areas. We knew that we had 40% of users who were eating one or less piece of fruit and veg per day, and that in East Ayrshire, Holly Health could tell us that was considerably higher than the UK population average. We also knew from exercise that actually, if we looked at the cohort with our type 2 diabetes patients, that their exercise was better than the population average that we had in East Ayrshire. And we started to recognise that actually a lot of our reviews that were happening in primary care based around advice and nutrition for diabetes weren't focused as much on exercise, and that could be something that we could pick up with there. We knew as well from our baseline data that actually the sleep patterns within East Ayrshire were worse than the local population, than the UK population average also. And given the evidence as well regarding reduced sleep and the associated risks for that, that is something that we wanted to be able to pick up. And we recognised, because we had data dashboards for each of the 53 practices, that our prevalence of long-term conditions was subtly different across those different areas. And the practices themselves were able to see these dashboards and to be able to recognise as well which cohorts of their population were choosing to use the Holly Health app. We could also adapt the data as well, depending on the partnership and the health board aims. And also because we had that data dashboard live, it was saving us time in our planning and performance team, and they weren't needing to take on this work as well. We could just see our data when we needed it. So our outcomes at 8 weeks for users were, on the whole, hugely successful. We looked at our general health, and there was improvement from 0 to 8 weeks in all of those general health areas. Mental well-being as well, that improved across the board. You may notice though that the top of the mental well-being is looking like it's reversed to the other three, but that one is actually anxiousness. So we obviously want to see all the other mental well-being scores increase, and we want anxiousness to decrease. So that was also a success. It was great to see the qualitative feedback that was being fed through as well, and we were able to use that as well when we were reporting back to the Integration Joint Board, who had given the innovation funding. We have over 6,000 users now, and some key outcomes include 35% improvement in moderate exercise, a 4mm reduction in systolic blood pressure, that's in 8 weeks, a 17% increase in energy, and a huge 31% reduction in anxiety. To be able to secure ongoing funding within the health board, we knew that the Innovation Fund had a set period of time, and we needed to be able to look at where else we could secure funding and try to move into more of a recurring model to be able to continue these successes across all 53 practices. When we looked at the GP appointments, it was fascinating to see that we were actually saving GP appointments and so reducing demand on general practice. For the average user, there was a reduction of 1.5 GP appointments per person per year. But when we focused in and looked specifically at those high service users, there was a 9 GP appointment saving per person per year. And the translation to that for our return on investment helped us to be able to secure funding to continue Holly Health for the further year. In the future, we're going to continue to roll it out. Secondary care services and our Ayrshire and Arran website host the links as well for Holly Health, and we encourage it. Cardiac rehab and our pain service management team are also interested and have agreed to be able to offer this to their patients too. And I'll hand back to Grace before we finish. Many thanks.
Thank you so much, Alexia. That was an amazing summary, 1,000 times better than I could ever deliver. So thank you very much. I think that wraps up both of our presentations.
Brilliant. Thank you. And I noticed there's not that much conversation in the chat. We've got about 10 minutes left, and I'm always delighted when we have the same number of people on at the end of a session as we had at the beginning, because that means you've kept your audience engaged. So thank you so much, all of you. I had a couple of questions, but it was kind of linked to the care planning question that I had at the start. And also, Ian, you really said something important about information being a determinant of health as well. And Grace, you saying that these are very personalised products and tools and services that help people. So I'm interested to know, if an area has a traditional care planning approach, they give a patient a document at the beginning, how you can feed that into either of your platforms and drip feed that information out throughout. And Grace, when you said it's personalised messaging, what influence is there from the practitioner on that personalised messaging? Because I've tried the Holly Health, and you obviously know as a user, you pop your own information in about yourself, but I'm trying to understand how practitioners can dovetail and make that personalised as well and bring that information in around the care plan. So that's to both of you. I don't mind who wants to take first. Pop your hand up, and if you
Grace, please feel free, Grace. Yeah, happy to come in after you.
Perfect. Sounds good. Yeah, it's a really good question. So as you've seen when you went through the process yourself, we're almost starting from scratch with the patient quite intentionally in the current model, because we want to be able to build a picture of them, like a whole picture of them, without having to rely on all of the handover of data already. So in some ways that's super helpful, especially with kind of public health deployments and deployments where we don't need to be interoperable to still deliver a lot of personalization. But going forward, we're doing a lot of work to integrate with various different services. Some cases to do with signposting, so patients coming in from particular places with particular challenges, so we know a small amount about them. But in other cases, we're actually linking up to medical records entirely, so that in future, when risk stratification is done across, let's say, an entire regional population, potentially Holly Health can be passed a portion of those users and the insights that are relevant for us to tailor some of the service initially. So we'll be able to pre-fill things like their clinical markers, their conditions, some areas that may be available in the records around kind of weight and that kind of thing. And then usually we will still need to ask a bunch of questions that aren't in the records, so mental well-being and exercise and things like that. There's a little bit of a combination, but right now we don't need to rely on talking to the system.
Okay, thank you. Ian?
Yeah, and from it's really good to hear. So our stance on this is really straightforward, which is no technology deployed in the NHS should be treated as like, hey, you've got this now, off you go, thanks so much for the contract. Like, there has to be local tailoring. We don't presume to know what any ICB, any PCN, any GP practice needs or how they operate. So we offer local tailoring of our service wherever we deploy, like within reason, but we do our best. So that could be as simple as signposting, right? It could be, let's say, so we have content in our app on kind of key topics for each condition. So for example, if you're using aid to manage asthma, there's a topic about like smoking and asthma, right? Same if you're using it for COPD. Now, all our content is bite-sized, kind of quick read, short hits to like level up a bit of health literacy. But at the end of every article, we signpost to more in-depth sources. Now, out of the box, aid does that at a national level. And it's all the things you'd expect, Aspirin UK, NHS choices, but we can tailor either that content or that signposting to be something local. So if there's a kind of smoking cessation program that's local, we can point to that. Or it can be slightly more in-depth. And for Suffolk, it was slightly more in-depth. We designed entirely new conversation flows to discuss the importance of preventative inhalers and also ways to capture why people are taking their reliever inhaler. For example, like I do this every time before exercise, or this time I'm actually breathless. I don't know what's going on. So, and this is the benefit of companies like Holly, like us, like companies at our stage, which is our whole point is to try and serve the population rather than like some of the big enterprise players. It's you get what you buy and that's it. I don't think that's ever going to be suitable. So that, yeah, this local tailoring has to happen on any commissioned digital product.
Okay, and I think, thanks. What struck me also was your stickiness of your platforms, that patients are actually staying on and using them, because that drop-off rate on a lot of health apps doesn't seem to be happening with yourselves. And I love it that patients feel confident about their improvement, and that's probably contributing to that stickiness. Alexi, your description of the amount of work you went into to make sure that you were being fully inclusive is interesting, because you offer in parallel routes of access to the service without people needing that digital device. That was really interesting. I think, do either of you have any insight into your most engaged users? Because I guess there's a notion often, oh, you know, we've an older population, they can't manage this, we've got a deprived population, they can't manage this. Of the patients that you've worked with most, which is the kind of cohort that you feel most engages with this kind of work? And that can either be by condition or symptom or age, demographic, or whatever. So Ian, I don't know if you can help.
Yeah, it's yeah, again, doesn't really come close. Our most engaged user in this population with Suffolk was someone in their 70s.
Okay.
So again, like goes against everything. Is contrary to everything people expect, which is, well, this is really only for people in their 30s, maybe early 40s. it's just not the case. But our most active user over this time period was in their 70s. Today, in kind of our most recent deployment, our most active user is the one with the highest degree of polypharmacy. So we allow patients to add their medicines during onboarding of aid. It's like a deliberate move to help them not feel like healthcare is paternalistic. It's like, it means we don't need to integrate like upfront, which slows things down, but it also means they feel like they have more ownership of their health kind of from the get-go. But that person had 16 medicines they're managing daily. Now, that's an edge case, right? But is it? I don't know, like people with comorbidity, 5, 6, 7, 8 medicines on average. So the people who are most engaged are all the people you'd expect, like the existing literature would say, they're not the people for digital interventions.
Okay. Grace, Alexia,
same as there's been a few studies, not by Holly Health, external studies that have been published recently that actually show again and again that older adults are the most engaged. And the cohorts that we see that are most engaged are kind of nearing retirement age. So I'd say 55 to 65, just pre or post. And there's a little bit more time, a little bit more focus. Also, it's becoming more important for them because they're noticing the decline in their health faster. So
that's useful insight, because I think that dispels the myth that it's older people can't do that, but actually they're likely to have more comorbidities, and as you say, we're all conscious of life running out for us, so maybe that's the time at which people engage to do something different. Melissa, I can see you popped your camera on. I don't know if you wanted to ask any questions while you were here. No, okay, that's a shake of the head. Okay. I guess I'm conscious of time. As Claire's already posted into the chat, the D&T network, everybody will be able to make contact with you on there, and we'll post some information out to everybody afterwards. Just to say, I found that super interesting. I hope all of the other listeners and attendees on the session did too. Next steps for either of you? How are you thinking of harnessing this issue that we've got around appears to be a lack of money? How can you support PCNs or practices or ICBs to kind of shift this agenda?
Holly, don't mind. Grace, do you want to go first? Don't mind.
Just a quick one from me. The majority of our time right now is spent lobbying. It's lobbying ICB leaders, lobbying NHS England, lobbying the government process that's currently happening to kind of set out the next plan. I think it needs to happen from all angles. So the more that everyone can push forward the need for kind of ring-fenced funding, especially for prevention, then the more likely we are to have it. So that's our focus at the moment.
Okay.
Yeah, I mean, it's a really good point, actually. We've been commissioned from like 3 or 4 or 5 different budgets over the course of the past 2 years. So part of it is an education piece and an openness to conversation. Our focus is like our thesis stands, which is the more conditions supported, the less pain there is on the patient. So we're just adding conditions as quickly, as safely as we can. And hopefully over the next 6 to 12 months, we'll have another 2 or 3, certainly in hands of patients to be tested at the very least.
And I guess, I used to commission an expert patient program years and years ago, and those patients all had commonality. They all had medication, they all had anxiety, depression, lack of exercise, diet, lifestyle advice. So I think the notion of single disease support needs to be shifted to, a holistic healthcare. So if you're, getting commissioned through different routes, I'm wondering if there's routes there out into what would have been public health, local authorities, to start thinking further upstream, and not just be thinking health focused, but think more about health and well-being. So that's super. Well, folks, it's 2 o'clock. Thank you very much, everybody, for your time.